Hello everyone. So in this video, we are continuing with the serious disorders. That is, we are dealing with the congenital heart disease. One of them is the tetralogy of Fallot. That is tetralogy of Fallot. The usual questions asked in the topic of tetralogy of Fallot is that is a question is regarding that is a 6-month-old baby was diagnosed to have the Fallot tetralogy. Then answer the following, that is discuss the hemodynamics, clinical features, and management and complications of the tetralogy of Fallot. Then second question is short essay is like that classify cyanotic congenital heart disease in children and describe the clinical features, investigations of Fallot's tetralogy, and management of the hypercyanotic spell. Then another short answer is like cyanotic spells in Fallot tetralogy, components on the hemodynamics of tetralogy of Fallot, then about the NADAS criteria, then about the clinical features and management of cyanotic spell. So these are the different questions which are asked in our university exam regarding the tetralogy of Fallot. So tetralogy of Fallot, which contains, the tetralogy of Fallot is the most common cyanotic heart disease in the children. That is about about 75% of cyanotic heart disease is the tetralogy of Fallot, and it contains 4 components. That is right ventricular, that is tetralogy of Fallot. As the name indicates, there are 4 components. That is, first component is the right ventricular hypertrophy, which give rise to right to left shunt. Then we have the pulmonary stenosis, that is right ventricular outflow obstruction. Then we have the overriding of the aorta, that is aorta usually arising from the left ventricular, which slightly shift to right side. That is overriding of the aorta. Then we have the ventricular septal defects. So in this picture, we can see that these are the 4 components of tetralogy of Fallot. That is, this is the right ventricular hypertrophy. Then we have the large ventricular septal defect. Then we have the pulmonary stenosis or the right ventricular outflow tract obstruction. Then we have the overriding of the aorta. So these are the components of the tetralogy of Fallot. Then about the hemodynamics of the tetralogy of Fallot, usually the large ventricular septal defect and pulmonary stenosis, which determines all the clinical features and the severity of the tetralogy of Fallot. That is because of the pulmonary stenosis or the right outflow tract obstruction. There will be concentric right ventricular hypertrophy without cardiac enlargement, and the increase in the right ventricular pressure will be there. Because of this pulmonary stenosis, right ventricular pressure which increases, and there will be shift of the shunt from the right to left. So the right to left shunt happens. There will be because of this right to left shunt, the deoxygenated blood from the right ventricle is shifted into the left ventricle. So that results in the production of the cyanosis. And also, because of this flow of the blood from the right ventricle to the stenosed pulmonary artery, which produces an ejection systolic murmur. So these are regarding the hemodynamics of the tetralogy of Fallot. That is because of pulmonary stenosis, right ventricular hypertrophy, and right ventricular pressure increases. So there will be the shifting of the shunt from the right ventricle to left ventricle, that results in the mixing of the deoxygenated blood, the oxygenated blood, that results in the production of the cyanosis. So it is a cyanotic congenital heart disease. And also because of the flow of blood from the right ventricle into the stenosed pulmonary artery, which produces an ejection systolic murmur. And the shunt murmur is not produced because of the large, there will be a large ventricular septal defect. The shunt murmur is not produced, only ejection systolic murmur is produced in the case of tetralogy of Fallot. And more severe the pulmonary stenosis, the less the flow into pulmonary artery and bigger the right to left shunt. And the sounds on examination, S1 is normal, S2 is single, only A2 part is here. The pulmonary part is soft and inaudible since the pulmonary artery pressure is reduced and delayed RVOT obstruction. Because of that, the single S2 is here. Then clinical features are, which may become symptomatic at any time after birth. There will be anoxic spells or cyanotic spells will be there, and there will be failure to thrive in the children, and cyanosis is developed. There will be progressive cyanosis. Development is variable, depend upon the severity of the pulmonary stenosis or the right ventricular obstruction. Then it is usually occurs at birth to 4 months of age. That is the period of birth to 4 months of age, cyanosis, that is progressive cyanosis develops. Then there will be, sorry. So then there will be dyspnea on exertion, that is assume squatting and exercise intolerance will be there. And on a physical examination, there will be clubbing, cyanosis, prominent A waves in the JVP. And while assessing the ECG, there will be, because of this right ventricular hypertrophy due to the pulmonary stenosis, there will be right axis deviation. And on X-ray, there will be boot-shaped heart, that is called in sabotage seen. This is the boot-shaped heart. On X-ray, there will be boot-shaped heart. That is because of the right ventricular hypertrophy mostly. Then the diagnosis is by the echocardiography and by the cardiac catheterization. Then what are the complications? It is usually asked as a question, what are the complications of tetralogy the infective endocarditis usually happens as a complication of tetralogy because of the turbulence that causes damage to right ventricle, and also there will be polycythemia. Second complication is polycythemia, that is because of chronic hypoxemia, that is due to the cyanosis, there will be a release of erythropoietin from the kidney that stimulates the erythropoiesis that results in polycythemia that causes increased viscosity. Then, because of the increased viscosity, the third complication is the thromboembolism. That is due to the increased viscosity. If emboli is septic, which migrates to systems and causes the brain abscess. Then, the fourth complication is the TED spells or the hypercyanotic spells or the hypoxemic spells. That is mainly due to the spasm of the right ventricular obstruction. That is caused by the spasm is caused by the excessive crying, vigorous feeding, or the exertion that causes a cycle of the events. This is the cycle of the events which showing the TED spells or the hypercyanotic spells. That is because of the crying or the vigorous feeding or the exertion, there will be spasm of the right ventricular right ventricular outflow tract. So that will causes the degree of the cyanosis increases. That is hypercyanotic. Because of the hypercyanosis, there will be hypoxia worsening. And this, because of this hypoxia, there will be the shifting of the metabolism from the aerobic metabolism to anaerobic metabolism. So there will be production of the lactic acids. Therefore, there will be lactic acidosis. So to treat that, we have to give the sodium bicarbonate. Uh, because of this lactic acidosis, there will be that act as a stimulus for the respiratory center. So the respiratory center is triggered and there will be hyperventilation. So this hyperventilation act as a suction effect that results in the increased chest expansion and causes the increased venous return. That is, therefore, again, the more blood is coming to the right atrium and then to the right ventricle, that again causes the increased spasm of the right ventricular outflow tract, and that again causes this vicious cycle. So that is the TED spells or the hypercyanotic spells. So for the treatment of this hypercyanotic spells, cycle വെച്ച് തന്നെ നമുക്കൊരു കാര്യം പറയാൻ പറ്റും. That is to treat this spasm, we have to give the beta blockers, and to release the hypoxia, we have to give the oxygen supplementation, or to treat the lactic acid, we have to give the sodium bicarbonate, and to depress the respiratory symptoms, we have to give the morphine or the opioids. So these are the treatment options for the cyanotic spells. Then about the management of the tetralogy fallow, the hypercyanotic spells have to be managed by advise the patient to sitting in the squatting position or the knee chest position. This is the knee chest position, which causes the mechanism like femoral vein compressed. While that patient is sitting on the squatting or the knee chest position, the femoral vein is compressed and the venous return reduces, and thereby there will be decrease in the RVOT spasm that will reduces the cyanosis. Then definitive is the surgery within 3 months is the definitive management. That is palliative. We have the aim is to improve the pulmonary circulation. That is the classical blood toxic shunt, modified blood toxic shunt, water shunt, and port shunt. These are the palliative surgeries. Then the treatment is hypercyanotic spells is by the squatting position or Nature's position, oral beta blockers to prevent the cyanotic spell, that is propranolol 0.5 to 1.5 milligram per kilogram per dose, and iron supplementation is for the treatment of the anemia. So this is the palliative shunt operations like Blalock toxic shunt. That is, there will be a shunt between the subclavian. That is, this is the classic Blalock toxic shunt. That is a shunt between the subclavian and pulmonary artery. That is classic. There is a shunt between the subclavian and pulmonary artery. And in the case of the modified Blalock toxic shunt, there will be artificial shunting is there between the subclavian and pulmonary artery. And in Waterston shunt, there will be shunt between the ascending aorta and pulmonary artery, and the port shunt there will be shunt between the descending aorta and the pulmonary artery. These are the palliative shunt operations, that is modified Blalock toxic, classic Blalock toxic, Waterston shunt, and port shunt. So that is all regarding the retrology fallow. So another discussion or the short essays regarding the patent ductus arteriosus. So the common questions are: describe the hemodynamics, clinical features, and management of the patent ductus arteriosus in neonates, preterm and term. Describe the hemodynamics, clinical features, and management of PD in children. So these are the usual question pattern asked in the patent ductus arteriosus topic. So as an introduction, it is the usually the patent ductus arteriosus, that is the persistence of the normal fetal channel connecting aorta to pulmonary artery. Before that, we have to learn about the fetal circulation very well. This is the diagram which showing the fetal circulation. That is, from the placenta is the site of the oxygenation for the fetal circulation, and the lung is not matured in the case of fetus. So from the placenta, the oxygenation happens, and the oxygenated blood is transported through the umbilical vein to this inferior vena cava through the ductus venosus, and through this inferior vena cava and the superior vena cava, the blood is reaching to the right atrium. There is oxygenated blood is reaching to the right atrium, and also there will be a foramen ovale will be there between the right atrium and left atrium. So there will be the flow of blood from the right atrium to left atrium directly because of the pressure difference. So and also so this blood will be from the right atrium flow into the left atrium and left ventricle. From the it goes into the aorta, and also the some of the blood is also going to the right from the right atrium to right ventricle, and right from the right ventricle it enters in the pulmonary artery. And this pulmonary the lung is not matured, or the lung is not inflated during this fetal period because of this lack of air entry. So there will be the blood from the pulmonary arteries through this ductus arteriosus reaching into the aorta again. So this is the and from the systemic circulation, the deoxygenated blood is through the umbilical artery, which reaches the placenta for the oxygenation. So these are the diagram which showing the fetal circulation. So here the ductus arteriosus, which is a shunt which connecting the pulmonary artery to the aorta. Then after birth, what are the changes happens in the case of fetal circulation? That is, after birth, there will be the ductus venosus closes immediately after birth. So there will not be any connection of the, and then also there will be aorta pressure rises, and the ductus arteriosus also closes in the 10 to 15 hours after birth. And then there will be lung expand, and that also causes the flow of the blood into the lungs. Then the left atrial pressure rises and the foramen ovale closes. So these are the four changes happens after birth. That is, ductus venosus close immediately after birth because of the removal of the placenta and the cutting of the umbilical vein. Then because of the crying of the child or the first inspiration, there will be expansion of lung. There will be, so that results in the flow of the blood into the lungs for the oxygenation. Then because of the left atrial pressure rises, there will be closure of the foramen ovale after 3 months. So these are the changes after occurring after the formation of the, that is after the birth. So that is regarding the fetal circulation and transition or the changes occurs after the birth. So usually before the birth there will be a shunt between the pulmonary artery and the aorta, that is the ductus arteriosus. But after the birth, it should be closed. So, but if there is any persistence of the normal fetal channel, that is a vascular structure connecting aorta to pulmonary artery, that is the ductus arteriosus, that is called the persistent ductus arteriosus. The communication is between left pulmonary artery and aorta, distal to the origin of the left subclavian artery. And epidemiology, 5 to 10% of all the congenital heart diseases, the patent ductus persistent ductus arteriosus, male to female ratio is 2:1, can be associated with the maternal rubella. That is, maternal rubella syndrome is most commonly associated with the persistent ductus arteriosus. The normal closure of the PDA, that is mechanism after birth, lungs expands and oxygen content of the blood increases, which was poor in utero. After cord is cut, there is a sudden shortage of prostaglandin from the placenta. Which these two factors which results in the closure of the PDA. And the timing of the closure is the ductus arteriosus closes functionally by the 24 hours after birth in the full term, and it closes anatomically by the 2 to 3 weeks, unlikely to close or reduction in size after a month in term babies. In the preterm, which may the closure of the PDA, which may take longer, that is up to 1 year. Usually, the prostaglandin, which maintains the patency of the duct, that is useful in the duct-dependent cyanotic congenital heart disease. In term babies with the patent ductus arteriosus, there is deficiency of both the mucoid endothelial layer and muscular media of the ductus. In preterm, PDA is structurally normal. Patency is due to the hypoxia and immaturity. Hence, the preterm PDA responds to prostaglandin inhibitors like indomethacin, while term babies require surgical closure. So this is regarding the introduction and the normal closure mechanism and timing of the PDA closure. Then about the hemodynamics of the PDA. Usually, the patent ductus arteriosus, that is usually the systemic BP is 120/80 mmHg in the aortic, that is aortic pressure, and in the pulmonary artery there will be 25 mmHg of the pressure. So there will be the shifting of the blood from the aorta to the pulmonary artery through this ductus arteriosus. So because of the large pressure difference in both in the systole as well as diastole, there will be, that is in the systole as well as diastole, there will be large pressure difference. There will be the flowing of the large amount of the blood during both systole and diastole through this ductus arteriosus to the aorta to the pulmonary artery. That will produce a continuous murmur. That is a continuous machinery murmur is a hallmark of the patent ductus arteriosus. So because of that increased flow to this left ventricular left side of the heart, there will be left atrium and left ventricle and pulmonary artery enlarges first, and the hemodynamics similar to post tricuspid shunt, that is BST, that is there will be the shunting of the blood from the right side to that is left side to right side, that results in the decreased oxygenation, and that causes the hypoxia. But there is no development of the cyanosis. Shunt depends upon the size of the duct, pulmonary vascular resistance, and LV function. If the patent ductus arteriosus is untreated, that results in the Eisenmangerization, that is reversal of the shunt. Usually, the shunt is from the left side to, that is aorta to the pulmonary artery. But if the patent ductus arteriosus is untreated, that results in the reversal of shunt. That is from the right to left to the shunt happens. That is called the Eisenmangerization. That will result in the cyanosis. So that is all regarding the hemodynamics. Then about the clinical features, the small PDA usually asymptomatic and detected on a routine examination by the murmur. If the patient is present with a large PDA, there will be failure to thrive, cardiac failure, 6 to weeks of age, dyspnea, and frequent chest infections will be there. And the signs are the large volume and bounding pulse, the wide pulse burst and prominent carotid pulsation will be there, and there will be continuous machinery murmur will be there. That is, the murmur of the PD site is at the left second intercostal space, type is continuous machinery murmur, and the qualities, it is a machinery murmur, transmission is at the back of, that is at the interscapular area, the transmission of the PDA murmur is there. Then mechanism, continued blood flow in the systole as well as the diastole because of large pressure difference between the aorta and pulmonary artery, that is during the systole as well as the diastole. Then differential diagnosis of continuous murmur is venous hum, AP window, bronchopulmonary collaterals in the top and a truncus arteriosus. The signs of the pulmonary hypertension like VSD is also there in the case of the patent ductus arteriosus. And P2 is not appreciated even with the pulmonary hypertension. And mid-diastolic murmur is here in the mitral areas. These are the clinical features. That is, small PD is asymptomatic, detected on the routine examination, but the large PD is failure to thrive, cardiac failure, dyspnea, and frequent chest infection is the signs like murmur is the important, that is continuous missionary murmur, that is that transmitted at the interscapular area back. Then the P2 is not appreciated even with the pulmonary hypertension. And therefore, also there will be signs of pulmonary hypertension is there. Then we have to investigate this patient. That is, we have to look for the ECG. There will be left ventricular dominance and left ventricular hypertrophy is there. On the chest X-ray, we have the cardiomegaly, left ventricular type apex, hyperdynamic pulmonary plethora, and enlarged supracardiac aortic shadow will be there. And 2D echo with the Doppler also shows the defect. Then what are the complications following the patent ductus arteriosus? Congestive heart failure, recurrent pneumonia, Eason micronization, that is, if the patent ductus arteriosus is untreated for a long time, that results in the reversal of the shunt, that is from the right to left, that is results in the Eason micronization. The similar natural cause as the VSD, which may occur at an early age if the larger PDA, and also infective endocarditis is another complication. Then management. In the preterm newborns, we have to administer indomethacin, that is COX-2 inhibitor, to decrease the patency of the ductus arteriosus. We have to supply 0.2 to 0.3 milligram per kilogram in the PD is likely to close spontaneously. In preterms, within 48 to 72 hours after birth, effective up to 2 weeks of age, indicated if hemodynamically significant PD with heart failure, respiratory distress is there. The side effects of the indomethacin is renal impairment and platelet dysfunction, and the contraindicated if renal insufficiency and bleeding tendency is there. And also we can give the ibuprofen 10 milligram per kilogram followed by the 5 milligram kilogram for the 2 days. And we can also give paracetamol, but there is a risk of the future autism will be there. The fluid restriction prevent hypoxia. Then treatment of the congestive cardiac failure with the diuretics and digoxin as needed. If the complication happens. Then in the term newborns, the indomethacin or the ibuprofen would never work due to structurally different PDA than preterms, may close spontaneously up to 1 month after birth, and surgical ligation, even the large PDA, which can be deferred unless heart failure refractory. The medical management with the treatment of the CHF, respiratory infection as in the VST, the timing of the surgical cost is large PDA with the pulmonary arterial hypertension, we have to surgically close by this 3 to 6 months. And moderate PD, we have to close with the 6 months to 1 year. The small PD, we have to close with the 12 to 18 months of interval. Then mode of closure is by the device closure using covalent occlusive devices or by the surgical ligation. These are the mode of closure in the case of the patent ductus arteriosus. And the surgical outcome is excellent and surgical mortality is nearly 0%. And the risk of endocarditis until greater than 6 months after surgery will be there. So no prophylaxis after 6 months of surgery. So these are all about the pulmonary, the persistent ductus arteriosus. So a short note is asked about the NADAS criteria for this congenital heart disease, and this criteria is used for that is when എപ്പോഴാണ് ഒരു congenital heart disease ഒരു കുട്ടിയിൽ സസ്പെക്ട് ചെയ്യേണ്ടത് എന്ന് തീരുമാനിക്കാനാണ് NADAS criteria ഉപയോഗിക്കുന്നത്. So NADAS criteria for the congenital heart disease that is congenital heart disease is possible if one major or two minor criteria which are present. The major criteria which includes the systolic murmur of grade 3 or more, diastolic murmur of any grade, and cyanosis and congestive cardiac failure. Then the minor criteria which are systolic murmur less than grade 3, abnormal S2, abnormal chest X-ray, abnormal BP, and abnormal ECG. These are the minor criteria. So if there is any presence of one major or two minor criteria, that is an indicative of the presence of congestive cardiac failure. Sorry, congestive heart disease, congenital heart disease. So that is about the NADAS criteria for the congenital heart disease. So that is all regarding this CVS chapter.